Yeah. So in our series, we also we didn't do the propensity score analysis, so we weren't able to sort of subtract out sort of the kind of the disease and high risk disease characteristics, but we also saw a decrease in overall survival, and we also saw an increase in non-relapse mortality, so treatment related mortality, and some of those are infectious, right?
Yeah.
So the sort of piggybacking of bridging therapy to lymphodepleting chemotherapy may be particularly harmful for these heavily pretreated patients.
But I postulate there's another option here, is that the bridging therapy may actually have an impact on lymphodepletion. So if you come into lymphodepletion with different milieu or different lymphocyte count, the efficacy of actually the lymphodepletion may be important, because we have found that the intensity of the depth of lymphodepletion can impact outcome with, in general, CAR T cells. So we'll get to that, I think, at a later time point. But these things may be all completely, connected and not easily separated.
And there's one other point I want to make about bridging therapy, is that all of these analyses with bridging therapy are before some of the newer drugs that we've seen come to market recently, and also be presented at this meeting, or at the ASH meeting this year. And so there are drugs that are more effective now, right, and more effective at debulking. And I think we'll get to a point later where, just like in ALL, we learn that tumor volume is an important predictor of response with lymphoma. And so if we are actually giving someone a more effective bridging therapy, and we can actually debulk them, we may improve outcomes. It's hard to know. Right now we just don't know if it's something inherent. It would just be a Band-Aid for something inherent in the disease that leads to lack of response, or if it actually is something about the tumor volume itself.
But there's a risk I do see with that, because all these new therapies that you mentioned are actually curative. So we may end up seeing patients at a later relapse stage. And then they may have seen bendamustine, for example, with Polar, and then we would have a hard time of generating a good product for the patient. So the other side is positive, but also could be quite detrimental to the success story.
Sure, and I couldn't agree with you more, and I just want to clarify that I was talking about using them after pheresis.
For a short period of time to bridge to CAR T.
We'll talk about other CAR T cells in a moment, but the other CAR T cell studies use bridging therapy. So axi-cell Zuma-1 was a little bit different, that it did not allow for bridging therapy, but the Juliet study as well as the Transcend study both allowed for bridging therapies.
But again, I think the main reason for that was because the production timing was not so fast. I mean, the beauty of the Zuma trials was that the drug was there in 16, 17 days in a very reliable fashion. So it's really important that you can get this drug for your patients when you need it, because we all know that if you have very many failures, you may or may not have another chance.
That's right.
In these patients to even get them to treatment. So I think that does come in.
In the Juliet study, it was closer to 50 days for the infusion time frame, which is
right. Initially, for sure. So are there any other characteristics of the patient that is going to predict who's going to have a good outcome?
Well, I think that the tumor volume is really very crucial. Just like slicing the patient into quartiles, it's very obvious that the patient with the lowest tumor volume, A, has the best response, has also the best long-term outcome, and also has the lowest rate of severe cytokine release syndrome or neurotoxicity. On the other side, the guys who come in with a very high tumor volume are the ones who actually, both on objective response rate as well as long-term controlled disease, are the ones which are really the ones.
So Fred, that came out of your data of analysis of the Zuma-1 trial, but I guess the question I would say is that's a very interesting observation, that if you got those people in that lowest quartile, they did remarkably well with, I think, 67% 1-year PFS. But let me just take it one step further. Does that mean if we pound on people before we give them CAR T cells and get them into whatever that disease range, that the outcomes are going to be better?
I'm not sure about that. Again, back to the real world evidence that we showed, that bridging therapy doesn't really correlate to improved outcomes. Hitting people with more therapies that aren't working to reduce tumor burden may not be helpful. I think that, though, the interesting finding there is that there may be an effector to target ratio when it comes to, at least with axicabtagene ciloleucel, and durable responses to that therapy in large B-cell lymphoma. And in fact, the quality of the CAR T cells probably matters as well. So you have to have quality CAR T cells and enough to overcome the amount of tumor. Hitting somebody with more chemotherapy may not reduce the tumor burden, and it may make the T cells worse if you do it before collection.
And even if you do reduce the tumor burden, it may be that tumor burden is a surrogate for other factors, that you have a more aggressive disease because you have a big tumor burden. It's not that the burden itself is necessarily the variable, it's why do you have a big tumor burden.
I think I also would like to stress that it is also tumor burden is one thing, but it's also T cell fitness. We do know that the patients who actually have their high peak expansion area under the curve are those the patients with the best disease control. So there may be an avenue of actually enhancing that expansion potential with other compounds in those patients receiving a CAR T cell product, and to maybe overcome this really detrimental situation.
I think rather than sort of pounding the patients with chemotherapy or pushing lots of bridging therapy, there's one other strategy we could take, which is, the NCCN guidelines don't necessarily have us repeatedly scanning our large cell lymphoma patients in remission to catch an early relapse, because historically finding an early relapse hasn't led to improved outcomes. But this data would suggest that if you can find someone early with low disease burden, if it isn't related to some other inherent aspect of their disease, treating them earlier may actually impact efficacy. And so we may be looking at a paradigm shift in terms of thinking about how we should survey these patients in
Well,
remission.
I think the data that's emerging with looking at MRD or free DNA, tumor DNA, is exactly where we should go. And we sort of see this patient is at risk, so we just take him in a little bit earlier, just scan him every 8 weeks, and then until we see clear evidence of disease, and then exactly go there with a low tumor burden patient, euglyphoresis, and giving them the product.
Yeah, there was some really interesting data using the CAP-seq technology that Jason talked
right,
about before in large cell lymphoma after frontline chemoimmunotherapy that was very predictive for relapse. And so that you're exactly right. That may be the most sensitive way, rather than scanning people all the time, to do this.